Hello everyone, welcome back to the Tokyo Living Podcast Injury Edition. Today we're going to be discussing concussion. Now, today's episode will have a specific focus on sports-related concussion. However, the physiological underpinnings of concussion are the same, regardless of the mechanism of injury. And the principles applied to diagnosis and rehabilitation are really the same, whether we're returning someone back to high-level sport or just to a normal working and normal activity environment. Now, the Concussion in Sport group had their 6th International Conference on Concussion in Sport in Amsterdam in October last year, and earlier this year released the 6th International Consensus Statement on Concussion. And because the research and the science around concussion is still relatively new, the way that we're going about assessing concussion and managing this condition is constantly evolving. And I think it's important for people, athletes and non-athletes, to be aware of some of the important elements of this sort of condition, and also just aware of the role of physiotherapy in the management and the return to function. So I'll just talk a little bit about what a concussion actually is. And we'll start with the updated definition of a concussion. Now, if you're watching the video version of this and it looks like I'm reading this definition word for word, that's because I'm reading the definition word for word. I will definitely not be able to remember this definition, but we'll just go through it and then sort of talk through some of the elements. So sports-related concussion is a traumatic brain injury caused by a direct blow to the head, neck or body, resulting in an impulsive force being transmitted to the brain that occurs in sports and exercise-related activities. This initiates a neurotransmitter and metabolic cascade with possible and axonal injury, blood flow change and inflammation affecting the brain. Symptoms and signs may be present immediately or evolve over minutes or hours and commonly resolve within days, but may be prolonged. No abnormality is seen on standard structural neuroimaging studies, computerized tomography, or magnetic resonance imaging T1 and T2 weighted images. But in the research setting, abnormalities may be present on functional, blood flow, or metabolic imaging studies. Sports-related concussion results in a range of clinical symptoms and signs that may or may not involve loss of consciousness. The clinical symptoms and signs of concussion cannot be explained solely by, but may occur concomitantly with, drug, alcohol, or medication use, other injuries such as neck injuries, peripheral vestibular dysfunction, or other comorbidities such as psychological factors or coexisting medical conditions. So a few important things there. The first is that a loss of consciousness does not need to occur for a concussion to be diagnosed. So you don't need to be knocked unconscious. There doesn't need to be that loss of consciousness there. And I think this is one of the things that people perhaps might not understand and might lead to someone not receiving an accurate diagnosis of a concussion. Concussion may be caused by a direct blow to the head, which is usually the most common mechanism of injury, but it might also be caused by a blow to the body. So if there's enough trauma in a blow lower down on the body that causes enough movement at the head, then that can also cause a concussion. And the other important thing is that often there's no abnormality seen on a scan. So we think of concussion as a functional diagnosis as opposed to a structural one. So when we're going about making a diagnosis of a concussion, it's not something that we go off and get scanned and that gives us a diagnosis. Our diagnosis is based on a clinical examination. What's happening when you have that trauma, basically that's inducing a depolarization and a change in the neurotransmitter balance within the brain. And this basically leads to local inflammation and interruptions within some of those neural connections. In terms of the management of concussion, this had been previously described in terms of the 4 Rs, the recognise, reduce, remove, refer. The concussion in sport group seemed to be somewhat obsessed with R's, and in the 5th consensus statement they'd worked their way up to 11 R's, and in the most recent consensus statement we now have 13 R's. And I guess this is just an easy way to remember the different elements of concussion management. So at the moment we have recognise, reduce, remove, refer, re-evaluate, rest, rehabilitate, recover, return to learn, return to sport, reconsider, and residual effects. And then the most recent ones to be added to that list are retire and refine. So we're going to go through these individually, and as we do, we'll sort of discuss some of the different elements of concussion management. I do think that going through these 13 R's actually provides a pretty good framework for discussing different elements of concussion. Some of them will have a certain degree of overlap, but overall I think it's a good way to break these elements down. So the first one is recognise. So when someone suffers an acute concussion, some of the symptoms that they might experience are confusion, a state of not being aware of the surroundings, delay in answering questions, or sort of that blank expression, that lack of ability to properly communicate with others. Things like headache, dizziness, nausea, a loss of balance, general sort of feeling of being stunned or dazed, and then also disturbances within vision, such as double vision, blurred vision, or seeing lights. And if someone is experiencing any of these symptoms, it's important to have them examined by a medical professional. So the first step is recognising that there may be symptoms there are symptoms that may be suggestive of a concussion, and that someone should go on for further testing. Now, if you're playing sport and you have a doctor or physiotherapist, courtside or field side, then they should be able to perform an acute assessment at the time. Now, the most common assessment is called the Sports Concussion Assessment Tool, and this is commonly known as the SCAT, and at this 6th consensus statement they released the 6th version of this, so we have now the SCAT 6. And so this is used, it was previously used as a concussion assessment tool right from the early stage through to the latter stage. However, we use the SCAT assessment now just as an acute assessment, and then after the sort of 72-hour period, then we sort of go on to a separate assessment. So if you are in a sporting environment where there is a medical professional present, then they should be performing an acute concussion assessment. So the next R we're going to talk about is reduce. Now, this comes next in their order. I probably should have shuffled up this order, but we're here, so let's talk about this now. Basically, as a society, but in terms of sport, wherever we're working with athletes and performing sports activities, we want to try and mitigate the risk of concussion as much as possible. So obviously over the last several decades, as both the acute and long-term sequelae of a concussion have gained more attention, there's been rule changes and equipment changes implemented to try and decrease the concussion risk. So the ones that were focused on in the 6th edition of this consensus were things like mouth guards, especially in sports like hockey, or for people from countries like Australia where they play different types of hockey where you don't need to be on ice. We would call it ice hockey. So equipment and rule changes are important. It's always a very contentious area where we're talking about rule changes, because some of the things that make many sports very exciting are some of the more violent aspects that do lead themselves to increased risk of concussion. So these sort of discussions around rule and equipment changes are things that are going to be ongoing and things that are going to sort of progress and evolve and become more refined over time. So other things such as general conditioning and also more sports skill related things such as developing awareness of certain elements of play that may put someone at a higher risk of direct head contact. And also, as I said, general conditioning, often when we're fatigued, our ability to react and our decision making might become poorer. And so, the more that we can improve our overall conditioning, the less likelihood there is of a concussion. Neck strengthening. Now, in terms of research around neck strengthening, it's still sort of in its infancy. There does appear to be some benefit of neck strengthening in more sort of non-contact or lighter contact sports, whereas we don't at the moment have that data for direct contact sports such as rugby, American football and combat sports. Now the thought behind that is that a certain amount of neck strength might buffer someone against a concussion if it was like a fall to the ground that caused that concussion, or just a knock to the body that caused secondary concussion to the head. But if you're being punched in the head, or if you're receiving direct trauma to the head with direct contact to another opponent, then we're not sure at the moment whether an increase in neck strength is actually going to be sufficient to decrease the amount of movement and the amount of movement within the brain that would lead to a concussion. From my perspective though, I think it's worth trying. I think in general, doing isolated strengthening such as neck strengthening is relatively not particularly time consuming, and at a minimum it's likely to decrease the risk of neck injury, even if it doesn't decrease the risk of concussion. So it's likely to be a net positive, and whether it decreases the risk of concussion or not, we're not quite sure at the moment. There's going to be, in the next decade or two, we're going to have greater research in relation to that. But as far as I'm concerned at the moment, I definitely think that it's something that the athletes performing sports, in particular contact sports, in particular sports where there's a risk of head trauma, it's something that those athletes should be doing. The next R we'll talk about is remove. So this can be viewed in a couple of different ways. So there's obviously the removal of the athlete from play immediately. So if someone does have any of the symptoms of concussion, then removing them from the ground and having them take no further part in that activity. From there, we need to look at an appropriate return to play or return to activity time. So we'll discuss that in a little more detail when we get to the rehabilitation stage. There is a risk of much further damage if someone sustains a second concussion within a certain amount of time. Now, we call this the second impact syndrome. So in general, like we explained earlier, concussion is primarily a functional diagnosis, not a structural one. However, following a concussion, part of the functional impairments is a decrease in cerebral blood flow. And because of this, if we have a second head trauma during this period where we have that decreased blood flow, we do risk a much higher degree of risk of injury to different parts of the brain, which then may result in further long-term damage. And there have been reported cases of death with this second impact syndrome. So it is important to definitely remove someone from the field of play at the time of concussion with no further participation on that day, and then making sure that they are fully recovered prior to returning to contact sport. The next R is recovery. Now, obviously, if you sustained a concussion, we want to recover from it. The typical recovery from a concussion is around 10 days. However, there is a massive range in which someone can recover from concussion, from anywhere from a couple of days to even up to a year. So while that 10 days is average time to recovery, the range is very broad. So we can't just say to someone after they've sustained a concussion, we're going to sit you out for 2 weeks and you'll be right to go back to play. So as with any injury, we can't make it purely time-based. It needs to be criterion-based, and people must fulfill each criteria as they go along their rehabilitation. Some of the things that might influence how quickly one recovers from a concussion. We used to think that females and younger individuals would take longer, or children would take longer. However, based on the research presented in the most recent concussion consensus, this isn't the case. So age and gender don't seem to have an impact on recovery time. Loss of consciousness, likewise, does not have an impact on recovery time. However, amnesia around the time of the concussion does. So if someone does have memory loss associated with the concussive event, then they're likely to have a prolonged recovery. Fogginess, that specific symptom may be associated with ongoing issues, and in particular dizziness, sort of 1 to 2 weeks, is predictive for development of persistent symptoms. Cognitive deficits, so issues with concentration, issues with memory, issues with cognitive functioning, within those first few days of the concussion are correlated with longer prolonged recovery time. And interestingly, access to care is associated with quicker recovery time. So if someone has access to proper management, proper diagnosis, proper care, then they're likely to have a faster recovery. If someone has a longer recovery from concussion, there may be specific elements of that concussion that are contributing to that longer return. And so these might be neck issues, might be oculomotor, so the coordination with the eyes and the brain. It might be the vestibular system, so those sensors that we have in our ear canals that give us information about the head's position in space. The vestibular system is often involved in prolonged concussion symptoms, issues with balance, and then psychological issues as well. And so if these are seen to be problematic, then we need to address these individually. And we'll talk about those in a minute when we talk about rehabilitation. The next R is rest. However, they've sort of changed that to rest and exercise, which sort of it seems a little bit contradictory, but I guess they wanted to keep their R's. So we definitely need relative rest. So we need someone to pull away from activities to allow the concussive symptoms to settle, but then we need to start applying exercise. And this is probably the biggest change in concussion management over the last decade. Previously, we thought that it was complete rest until someone's concussion symptoms settled and then start to build back up. But I guess it's sort of following in line with other musculoskeletal conditions where we know that complete rest isn't useful for the healing of a tissue, and the tissues need loading. Likewise, our brain needs loading, and we've come to see that low load cardiovascular exercise, and we call this sub-symptom threshold aerobic exercise, can start as early as 2 days post-concussion. And so this is relevant for both acute and chronic concussion. So we're basically exercising to a point at which someone might experience a slight increase, say a 2 out of 10 increase in their concussion symptoms, but if it settles within an hour, then that's fine. And that's shown to actually improve the rate of recovery from the concussion long term. The next R is refer. So if a medical professional has made that diagnosis, they're monitoring, and they can see that something, they're not recovering as expected, then you're referring out to perhaps for a neurologist, a vestibular specialist, a physiotherapist. So if there are sort of cervical issues, obviously physiotherapists are experienced in concussion management from a general perspective, and we certainly perform vestibular, oculomotor rehab as well as just general concussion-related load management. However, we are especially specialised in the management of musculoskeletal conditions. So if the neck is relevant to someone's concussion, which is often the case, someone will have, if there's enough force, there was sufficient force to cause a concussion, there's often sufficient force to also cause a neck injury. And it might be that someone sustained an initial concussion, but it's actually some of the neck injury that is contributing to the ongoing symptoms there. So we've definitely had people in the past that have really responded well to neck treatment in relation to their concussion symptoms. We might need to refer someone to a psychologist if there is deemed to be some psychological impact of the concussion. And obviously, again, if there was enough impact to cause a concussion, there might be enough impact to cause some psychological trauma, which is impeding the recovery. And people might also have underlying mental health issues that are also contributing to the concussion. The next R is re-evaluate. As we're going through this management process, we're looking at our objective markers and subjective markers of how someone's concussion is progressing. And if someone has persistent problems, looking at what are the source of those problems. Now, we used to deem anyone that had ongoing concussion symptoms after 10 days as persistent. We now consider someone who has had symptoms for more than a month as persisting concussion symptoms. So I guess some of that terminology change is just to put it in a little bit more of a positive light, that the symptoms are they're going on, but it doesn't put them into a category where they've got this rigid problem that is there and it's not really responding. So they've got these persisting symptoms, but there's still that scope for a decrease in their symptoms. Once they get to 3 months, then we consider them persistent. And so, the persistent post-concussion syndrome, PPCS, often associated with cognitive impairment, ongoing headache, difficulty with balance, some dizziness, and difficulty sort of focusing and reading, ongoing fatigue, intolerance to ambient sound. We have sort of photosensitivity, sensitivity to light, fogginess, that sensation of just feeling slowed down, some mood disruption, and even some ongoing amnesia. So if those symptoms are persisting past 3 months, then it becomes a little bit more of a complicated case and complex case. And so that's when it's really important to have a multimodal approach with different health practitioners involved, and making sure that all those elements that we talked about before are continuing to be assessed and managed accordingly. The next one is return to learn, and this is obviously more relevant for younger athletes who are still at school or university. I think the same principles can be used for returning someone to the workplace. We used to think that someone needed to avoid screens for basically as long as the concussion symptoms were present. We now know that the avoidance of screen use is really only relevant for the first 2 days. So we keep someone away from tablets and computers and televisions for 48 hours, but then after that we can reintroduce those modalities, provided that the symptoms don't increase. There may need to be modifications for work and school environment. So working habits may need to be made to change. So instead of working for 2 or 3 hour chunks at a time, you might need to break that up into 15 minutes with a couple of minute break in between, just to try and allow the visual system and the brain to recover from the stimulus that it's receiving. With school, there may need to be discussions with school and with teachers in terms of curriculum modifications, testing modifications, so that the initial cognitive load when someone returns from a concussion isn't too great to impair their recovery. However, it is important that students go back to school as soon as is safe. There used to be a trend of having people avoid school for long periods of time. However, we've sort of moved away from that, and we now encourage an early return to school for obviously the social elements, but also the effect that it has on the ongoing academic progress of the student. And then return to sport. As with any return to activity, it needs to be done in a graded fashion. So we've talked about how we would initially start someone off with a sub sub-symptom threshold aerobic exercise. We basically progress that to more intense exercise, and then you progress to using resistance exercise, where you do have an increased cerebral blood pressure when you're performing weight training. And then progressing back to including more of cognitive demand, so on-field work, reacting to external stimulus, whether it's visual or auditory stimulus. And then, as we're going through this progression, we're making sure that someone's symptoms don't increase. So if someone does have an increase in symptoms as we're progressing the activity, then we basically regress to that previous level. And then once someone can tolerate that, we start to gradually increase the amount of partner drills, working with other people, reacting, and then if it's necessary for the sport, reintroducing contact drills, and then gradually progressing back to full contact practice. And then once someone has returned safely to full contact practice, then returning back to play. And at that point, depending on the condition, someone might need protective headgear, and especially if there have been facial or skull fractures associated with concussion, then other protective equipment might be required. The next one is reconsider, and I think this goes in with the next two, which are residual effects and retirement, if it's an athlete and it's relevant to that athlete. Reconsider, we're essentially reconsidering whether that sport or continuation of that activity is actually beneficial for the person. We do know that professional American football players do have higher rates of cognitive disorders and dementia than other populations, and we do know that professional football players and soccer players have greater mortality rates from amyotrophic lateral sclerosis, or ALS. Now, there's obviously been a lot of press attention and a lot of debate regarding the long-term effects of repeated head contact. And we do know that diseases such as dementia and other cognitive diseases and the mortality rates associated with those in American football players, for example, are greater than control groups. We also know that in former American football players and even soccer players, there's a greater incidence of amyotrophic lateral sclerosis, or ALS. It's important to note, however, that these studies don't really show causation. They're correlative studies, and there's a lot of factors that can influence the outcomes of these studies. They don't really take into consideration other genetic factors, socioeconomic factors, education level, smoking, hypertension, other comorbidities that may be relevant. CTE, or chronic traumatic encephalopathy, is something that's been talked about a lot in recent years. And to make this more of a clinical entity, it's been updated in terms of its definition as CTE-NC, or CTE neuropathologic change. Now, this is something that can only be diagnosed post-mortem. So essentially what happens is you get an increased degeneration or death of the neurons. And as I said, this is diagnosed after someone passes away. So because of that, we still don't have a lot of research in regards to the correlation between the incidence of these post-mortem findings and the either numbers of traumatic brain injury or numbers of concussion or participation in certain activities. More recently, TES, or traumatic encephalopathy syndrome, has been proposed as more of a clinical diagnosis that is thought to correlate with some of the changes that occur with CTE. So this is still in its early stages, but as we have more research correlating the structural findings with the symptoms, we may be able to identify earlier those patients that might be at risk of development and then be able to instigate an earlier treatment protocol. So even though there is still a sort of positive solid research linking these symptoms, anecdotally we do have more and more previous athletes, former athletes and even current athletes coming out experiencing long-term cognitive changes that are attributed to sports-related concussion. And so because of that, someone who is involved in sport where there is a risk of concussion, and especially once they go down the path of having multiple concussions, because as someone experiences more concussions, the concussion symptoms seem to be more severe and the impact required to cause a concussion is often less and less. They need to put that into context with the demands of the sport, what part that sport plays in their life, whether it's their source of income, whether it's something that's very meaningful to them, or whether it's just an enjoyable hobby. That needs to be taken into account when making decisions regarding return to play and long-term participation, and that needs to be weighed up with family commitments and family responsibilities, work commitments and study commitments as well. So I hope that has been of interest to you. If you do suffer a concussion or you know someone who has suffered a concussion, please make sure that they get the appropriate care and have a structured, graded return to learn, return to work and return to sport program. And if you are participating in sports that have a risk of concussion, then for the sake of yourself or the people that you're participating with, try and become familiar with some of the symptoms that might be evident after a concussion, so that they can you or the people that you're with can seek the appropriate management. Thanks very much for watching, and we'll look forward to seeing you on the next episode.